So here we've got Karen Price with Becky Platt. Karen is a very experienced GP and she's coming with a huge amount of information for us today. Karen's got a very long list of accolades. I'm going to actually cheat and use my phone a little bit because she is the immediate past president of the Royal Australasian College of GPs. She's the co-founder of GP Down Under, which is a 10,000 strong learning peer support advocacy. Karen was telling me about her PhD that's about to be submitted, all on peer connection in Australian general practice. And in conversation with Becky Platt, they will be talking about primary care. Thank you.
Okay.
Oh, we're doing that now.
No,
okay. We might go over there.
We're literally doing it now. Go. Okay. So Karen, let's just go there. There's definitely some stuff stereotypically that GPs do that really annoys us in hospital. So my personal favourite is, "Dear doctor, please do the needful."
Yeah.
Okay, back at me. What really gets on your nerves?
Well, obviously we don't really condone that either because we want a proper clinical handover, and we've had some colleagues of ours write in the MJA Insight about what a clinical handover means coming back from secondary and tertiary care, because at least you get that, because we don't get anything back.
Oh.
No, we do. Better hospitals we do, better places we do. But it can often go missing. So look, this is a really big issue for both of us, I think, having that interprofessional communication. And we want to say it's not a discharge summary. I've got a daughter who's going through the hospital training, and it's always put down to the last thing, the discharge summary. We want a good handover back. And we know that you want a good handover to you from us. But there are huge issues in general practice. It's been progressively defunded through freezing, the time barriers, the complexity of presentations that come to us. The fact that someone's even bothered to write you something, please do the needful, is probably a recognition they want something back, but it's not, sometimes people are just sending people in and say, just go to ED. You're not getting anything. So it's a time issue. And to take the time out from, maybe a 15-minute consultation, maybe longer, maybe less, to write another coherent summary of, of a good, what I would think is a good summary, would probably take 5 or 10 minutes. Now, if you do that with a patient in the room, they're telling you something else. It's very hard to listen to that, write that, make sure you don't miss the red flag. If the patient steps out of the room, you no longer get paid. So it's a really a big issue for us in how we manage safe care across that boundary, and we think there's a role for better funding and better recognition of how important that communication is.
For sure, because clearly what we're actually all trying to do is do the right thing for our patients, isn't it? And I think often it becomes kind of adversarial in a way, and it feels like each one of us is creating work for the other. But when we feel like that, the person who gets lost in the middle is the patient, isn't it?
Yeah.
You've done lots of work on making sure that the patient doesn't fall through that gap. Do you want to tell us a bit about that?
No. What am I talking about?
What are you talking about?
Lots of.
Are you joking me, or do you need a prompt?
Yeah, no. Give me a prompt. Give me a prompt. What do we talk about?
We were talking about your collaboration between primary care and hospitals and the other collaborative work that you've done with your GP groups.
So in my role as president, we were talking about trying to have one health system, which we think is really important because there is a jurisdictional barrier between us of funding, and so hospitals, sort of everything stops at the hospital door, and for us everything stops once you move out of general practice. So we've been trying to lobby very hard to have one jurisdictional health system. Whether that's state-based or nationally, it's hard to know, and I do call it the Federated States of Dysfunction, because it would be better for the hospitals to recognise there's a whole professional workforce out there, not only GPs, but lots of allied health and so forth out there. So we find it challenging. That's often forgotten. When people talk about health, when you see a politician, they're very often standing in front of a hospital, or these days often in a pharmacy as well. So, which it is difficult.
Yeah. So I guess there's some stuff that we can do in terms of, using our voice collectively to try and influence policymakers around this?
Yeah, I think there is a role for that. So there's obviously the systems effect. So knowing that there is a formal system, which there's probably multiple formal systems, often very punitively based around compliance. But there's the informal system. So that is, how do we talk to each other? When I pick up the phone to my private consultants, it's a much different consultation, much different in tone and respect than often when I ring a public hospital. I very rarely can get through to the person I want. There's just so many barriers between, and by then another 10 or 15 minutes has gone by trying to speak to someone regarding an issue that I think is important that can't maybe not be written down, that needs to go with the patient. Trying to get the information into the system of hospital is really difficult. And I assume for you it's the same. When my daughter talks about trying to ring the GP, she throws her hands up and says that she often gets the same barriers back. Can't get through, the doctor won't answer, whereas I think it's really important that we do maintain that we always interrupt. I always at least interrupt my consultations to speak to a doctor. But again, we've also got more of a part-time workforce, and people may not be there on that day. So there's a lot of institutional challenges.
And what can we do about building relationships across those boundaries? Because it's far easier for me, if I'm ringing Karen and you're taking a call from Becky, that's far easier than me ringing the GP. So how can we address that?
So I was really interested in the first discussion with Damien and crew this morning regarding feedback, and I know in my research that if someone gives negative feedback and you don't know them, you take it as criticism, that person's the devil, and you never speak to them again. Whereas if there's someone you're going to listen to them and you actually put it into a quality improvement framework. So it's really important to build those relationships, and much of our policy is blind about the power of relationships. It's not talked about, we don't value it, it takes time, that's time away from patients, but having those relationships with secondary and tertiary and quaternary colleagues is really important. So if you're a paediatrician going to meet your local GP, so we know who you are, so we can pick up the phone, or you can pick up the phone and say, look, I need some more help with this patient, or Vicky Berkey. It's really helpful. Having these kind of things, I'm thrilled to be asked here, so thank you very much for asking primary care and general practitioners who are here. Fantastic. And having those conferences together. We went to CODA, which was really good too, to have that. And I think we've got to lead the way. We've got to show the government that we actually do get on, that we actually can't be played off against each other, that we actually want to do the best thing by the patient, that we're not sort of money-hungry grubs who exist to take treasury from underneath them. So I think it's really important that we stick to that script, which is our professional values.
And I think you've done some work creating groups and communities online to try to build that a bit, haven't you?
Well, part of that was my frustration with the college, where it was very difficult when I was chair of the Women in General Practice to communicate with the women. So we, long story short, set up a forum where we focused on learning and doing case bases, because general practice is isolated. We see one patient, one room at a time, and that's it. We're running past each other. We don't have mortality or morbidity meetings and so forth to debrief. So I set up this forum. It's now through word of mouth and sticking to those strict organisational principles of advocacy and peer support and peer learning. We do de-identified case-based learning, which has been really helpful. Now I consciously have to model that I don't know anything so that people can feel safe to ask questions. So it's really important to have a clear understanding of what it takes to actually admit that you don't know something, and get over that medical student stuff where you have to be the smartest in the room in order to survive the bedside ward rounds with the professor from hell. So just how we're kind of trained. So which is it's difficult. So how to change from that competitive environment that we're all groomed through into that collaborative environment, and how to maintain those relationships. And any of you who've done psychotherapeutics know that there's a real relationship, and there's the working and learning alliance, and then there's a transference and counter-transference. So the real relationship is like the Google Games room, sort of where you break bread with each other, you talk across the lunchroom. I've seen the discourse on Twitter or X that the lunchrooms are being taken out of the UK working environment in hospitals, which is a tragedy, because so much good stuff happens there that supports quality improvement, that supports people being able to speak up. and same in general practice. So having those times where you can actually have some time out to cement the relationships. Social stuff is really important. We're social animals. We rely on trust. We have to sort of get into that kind of environment where we have that, what do you call them, diamond dogs. So my research is about the diamond dogs. My research is actually about the informal peer relationships that GPs have with each other that support a progressively graduated movement from learning and picking who's you're going to ask, right through to really quite involved debriefing in an informal way. Because if you tell a group of doctors to go to debriefing, and particularly GPs, you need to go to the psychologist, they're going to go, no way, I'm not going. So this is a lot of people do it very naturally. There's interestingly some people who don't, who do a different form. There are a couple of disconfirming voices, so that's really interesting. We've got to bear in mind there are some people who don't, for various reasons, don't like to reflect so well, or who don't do it very easily. And so forcing people into that kind of environment is probably not a good thing for everybody. And I think that's an important point too, because we're all different.
Absolutely. I know that one of the things that you're passionate about is making sure that patients get good healthcare when they've got chronic illness, and something about, who holds on to that patient. Do you want to talk a little bit about that?
Yeah, well, in general practice, if someone's got private insurance, it's easy. I mean, you can send them off to a group of people, and allied health in particular, physio, dietitians, and everybody, and they'll generally get the care. And I generally will match the patient, as you all would do, to the allied health person you think they'll fit best with, because again, it's about human relationships and who fits with who. Whereas if they're a public patient, they don't have a lot of money, or they don't have private insurance, it's very hard to get them that kind of wraparound care. We just can't. In hospital, you can go and provide thousands of dollars on the taxpayers to give them some degree of care, but once they come out to the community, we cannot. They just can't afford a physio, they can't afford dietitians. So we have to come up with all sorts of different ways of trying to manage that in general practice. We do have care plans, but most allied health will charge a gap fee above that, and there's very few who will bulk bill. So we're still stymied in trying to develop the care that we need for the inverse care law. So, which you're familiar with, I think, that the vast majority of health resources are consumed by usually the lowest socioeconomic quintiles, and they have the least access to healthcare. So we're in a real challenging time in general practice, because we've had to reduce bulk billing by a significant amount to keep the doors open, and that's really difficult. And trying to decide who's eligible for a bulk billed 50% discounted consultation is, I'm sure you face the similar issues, but you've got a public outpatients, which I think helps, whereas we don't have that in general practice, so very difficult.
And are there patients that we are potentially sort of holding on to in secondary care that could be easily managed by you, she says, in a loaded question way? A
loaded question? Look, never the paediatrician.
Obviously not, I'm talking about us.
No, nobody here. Look, it's sometimes frustrating. Like, I mean, I related Becky a story about someone having their 6-monthly Prolia injection from a bone endocrinologist who's in their 86 years of age. I don't see what the point of that is, or managing chronic kidney disease, which we do a lot of. Like, when I started in general practice, the hospital-based specialists would often do the needful, they'd do the management, and they'd make recommendations and then send them back to our care. But what I've noticed over the 30 years I've been in practice is that's not happening so much. So it is obviously a tricky thing, because we've got patients who do need to see specialists. It tends to happen more so in private specialties, but I do wonder about the public hospital outpatients, how many people need to come back. And I'm aware from talking to everybody here, and also my daughter, that a lot of patients don't have a general practitioner. So, and how do you, and they like to move around, and they're very, very mobile, and that's very difficult too, because they haven't built up a relationship of trust, and not every GP suits every patient, not every patient suits every specialist, so they have to actually work at that relationship too.
I think that's one of the things that's been lost, hasn't it, now that we don't have family doctors in quite the same way. You know, we don't have that relationship and that knowledge of the family and the social context in the way that we used to have.
Yeah, I think that's it's still, I think about 86%, if I can remember the percentage of patients will see their GP, but it tends to be the patients with chronic disease, who are in the older age groups. And look, young people, having got a family of young people, they move around and that's hard. But trying to give health literacy to a population, I think some of the estimates of the health literacy is probably about 24% of the general population in terms of understanding where and how they need to navigate their own healthcare. I think that's something that we do need to be involved in as professionals, to be out there talking to our communities and bringing back that sense of community. I mean, I know amongst the patients and particularly adolescents, the isolation that's happened post-pandemic, but was probably also there through any number of reasons, sociocultural reasons. I think that's something that we can actually provide a bit of a professional healthcare home for patients, and that doesn't mean necessarily giving it over to the government, but with paediatricians, in particular with adolescents, giving them a safe place they can go if they can't get good information from home or from TikTok or anywhere else.
I actually find that quite reassuring, that 86% statistic, because I know that that would not be echoed in the UK, and that says to me that that general practice is actually a really safe space for young people, maybe particularly young people who are struggling with their mental health, but don't yet need onward referral to child and adolescent mental health services. What would your thoughts be about supporting those people?
I think we're seeing, first of all, everyone has mental health. Everybody has it, and I think the way we talk about it is tricky. So there are a lot of patients who secondary and tertiary care never see, that general practice sees, and one of the most common presentations for a general practitioner is mental health across the populations, and that comes with every chronic disease. It comes with every presentation, more or less extent. So we're seeing a lot of psychosocial distress, and my understanding is a lot of that's related to the sociocultural things that we're going through, unemployment, the cost of living, education costs and so forth, rather than a mental health diagnosis. And you know, I think sometimes the way that it's positioned in policy is a little bit black box, and whereas mental health is really a distress signal from our community that all is not well. And I think we've got, what is it Virchow says, we're the attorneys of the poor in a social way, and I think we need to be talking about how we support young people with a safe place.
Yeah, absolutely. Places, yeah, absolutely. And just one final thought based on something that we discussed earlier, and I think just owning the fact that sometimes we're guilty in our discharge letters, or I think probably particularly from ED, we write these throwaway things like GP to refer to blah blah, or GP to chase results.
Nothing gets the forum more alight than a GP to chase letter from secondary care. Nothing gets it more alight than that.
Yeah.
So, if we're gonna have to follow up a result, please copy us into it. And we know it's not perfect, and so forth. But yeah, please don't do it.
Okay. So how about, we could agree that we will never send those letters again, and then hopefully we'll never do the needful.
Well, I'd like to guarantee that, but I can't guarantee that, sadly. Not until the systems get better, and we get better. I'm not going to send a letter like that to someone I know. I don't think I've hopefully ever sent that letter. But
no.
I think we're going to do it less if we know the people that we're talking to, and maybe it's a phone call that we need to give to the. It used to be ring up the AO in ED, ring them, but that doesn't happen so often now. So I think we've got to look at how we do that. Shared health summaries would be good, but of course the medical record thing, whatever it's called, My Health Record, is a PDF shoebox as far as we're concerned. A lot of people say it's better and it's getting better, but I think it's still got a way to go in terms of the volumes of information and being able to look very quickly to find out where the issues are, the most recent issues.
Thank you. We're talking to each other, and that's a great start.
Yeah.
We'll end it there, and I'm sure there'll be time for questions later.
Yep.
Lovely. Okay, can we all clap? Thank you.